I'm just going to say a few words about procedure before we begin. Okay, so Yoshi Ikehara is the Minister for Justice in Ireland. He's going to say a few words introducing the bill. Then the committee will convene its hearing and we'll hear from both sides. I can't remember, Kathleen, which side we begin with.
We're going to begin with
those who are for supporting the bill. Kathleen is the chairperson of our committee today. You will take some interruptions, I presume, but okay. Then the committee will retire for a few minutes to consider what to propose to the House. We'll make our proposal to the House. Maybe the Minister will comment on it and give you options to vote on. And then you vote as if you are the Parliament, and then we have the result. So, Yoshi, over to you.
Good afternoon, ladies and gentlemen. I'm a Prime Minister here, and my name is Yoshi. Yoshi in Japanese means good. So that means I'm good Prime Minister. I'm sorry, just Minister, I'm sorry. And so I'd like to introduce you about the new bill which try to amend, abolish the coercive treatment and involuntary detention. It's quite new law all over the world. And so I, as a minister, are very much proud of this kind of thing. So as you know, 2006, the Convention of Persons with Disabilities was adopted, General Assembly of the United Nations. And 2007, our state signed the convention. Since then, our government have emphasized too much commitment to proceed for ratification as quickly as possible. However, it is necessary to harmonize our current domestic laws with the CLPD for the ratification. As for the Mental Health Act 2001, it provides for involuntary detention of persons with psychosocial disabilities, as you know. And it does not articulate that coercive treatment, whether or not coercive treatment is justified. However, so it is necessary for us to comply with the CLPD to abolish this kind of practice and current mental health law. And so I'd like to highlight 3 points of view. So we propose this kind of new bill. The number one is a kind of normative requirements of the CLPD. As you know, Article 3, Article 12, Article 14, Articles 15, 17, 19, 25. So demand to abolish the involuntary detention and coercive treatment. Especially Article 12 requires equal recognition of the legal capacity, and Article 14 prohibits deprivation of liberty on the basis of disabilities. And I think it's very important to see significance of Article 17. As you know, Article 17 guarantee guarantees the integrity of persons with disabilities. It will require the total abolishment of coercive treatment. And Article 19 requires inclusive society, and Article 25 requires mental health service providers to comply with free and informed consent. So according to these articles, we have to change the situation. We have to abolish the involuntary detention and coercive treatment. The second point of view is a kind of effectiveness. I think coercive treatment or involuntary detention do more harm than good. So it has, those treatment or detention has serious and irreversible side effects, and also anti-therapeutic effect. A person once committed involuntarily, he or she never wants to go to the hospital or never to use psychiatric treatment or psychiatric help. And so side effects or anti-therapeutic effect is very serious. And as you know, those kind of things may shorten the life expectancy of persons with psychosocial disabilities. It is reported that those people, life expectancy of those people shorter than 25 years shorter than general public. And number 3 is a kind of technical point of view. I used to be a practitioner, lawyer, and I think it's technically impossible to provide criteria of involuntary detention and coercive treatment without any vagueness or without any ambiguity. I'm sorry, I will finish. So, innocent person with psychosocial disabilities inevitably involved into involuntary detention and coercive treatment. I think more persons with psychosocial disabilities are victimized than rescued by current law. So those three points are main reasons to support or propose this bill. So I'd like all people to discuss this kind of thing. Thank you.
Thank you very much, Minister. The Minister, as you will have gathered, the Minister's name is not a good old Galway name, but nevertheless, I say it presented a very exciting case for this piece of legislation. I'm chairing the meeting today, and we will have 6 participants, 3 each side, for and against, and it was agreed that the group in support of the bill will speak first, and I would like them now to introduce themselves, and they will have 21 minutes for the entire team, which breaks down at 7 each, but they can determine that between them. And I'm hoping that the timekeeper, if there are interruptions or questions asked, that will be taken into account as well. I wouldn't like to see people lose time in making their arguments because we don't understand or because we want them to flesh out a point. So the team in support, would you please step up and introduce yourselves?
We are voice to voice. We want voice to choice.
And we won't be having any more of that.
No. Ladies and gentlemen, can you hear me? I'm very grateful to have this opportunity to tell you my story. Sorry. My name is Ma. I have been in the hospital for 3 months in Ireland in a psychiatric hospital. My father talked to the doctors before I was admitted. My father tricked me into the hospital. Unfortunately, I was not aware of what was ahead of me. He came with the nurse to my home and persuaded me to come to the hospital. They said it would be beneficial for me to get physically examined. This happened in 2006 when I was 34. At that time, I lived with my girlfriend. They kept me there for 3 months. After 1 week, I contacted my girlfriend and told her that I'm fine and I want to return to home. However, my girlfriend understood me but thought I should obey to what the doctor said, as she was not a professional and trusted the experience of the doctor. I'm not a troublemaker. I obeyed the doctor and the nurse. Because of that, they did not use force or punishment on me. So I had a good family support. They treated me well. Otherwise, it would have been another story. Others were not as lucky as me. For example, there were situations that the nurse kicked the patient for no reason. It seemed to me that violence was particularly bad when the nurse had a bad day herself. I saw electric shock treatment 3 times used on people who simply disagreed with the doctor or the nurse. It was randomly used purely as punishment, not for medical treatment. My legal capacity was denied. The moment I entered the hospital, nobody spoke to me personally, only to my father. I was completely silenced. There was no explanation, nor any diagnosis given to me during the whole time. I learned quickly to conform all the time with the doctor and the nurses, so nothing would happen to me.
We are Voice and Choice and survivors of psychiatry, and this is just one of our stories. It illustrates the bigger problem there in our country. Our research has shown that in Ireland there are 3 million people, and 40,000 adults have been in and out of institutions, and hence are registered as persons with psychosocial disabilities. There are many more without access and who may have psychosocial disabilities. There are 8 institutions in the country with a bed capacity of 3,000 people. Yet, currently, there are 5,000 people living in institutions right now. And statistics show that 20% of them have lived there for more than 10 years. About 50% of them only have been there about a year, and 40% underwent some form of restraint. In most cases, it was a way to punish someone whenever they did not conform. They were known as troublemakers. 70% of them had no consent to the treatment, and not one of them could represent themselves. Only 20% of them were informed of their rights, so there was no attempt to even try an alternative. We are all human beings, and we are entitled to our rights by just the virtue of being human beings. And no human being should be entitled to deprive another human being of their dignity. Freedom of choice is all about human dignity. It is about exercising your will and informed consent, which is built through trust, not coercion. The Convention on the Rights of Persons with Disabilities is an opportunity for us to reimagine and rethink how we, as a society, treat persons with psychosocial disabilities. This bill is in line with the CRPD principles and is the first step towards ensuring dignified living for persons with psychosocial disabilities. The bill provides for recognition of legal capacity of persons with mental health problems on an equal basis with others. It prohibits coercion and forced treatment and upholds the voice and choice of the person through full and informed consent. We keep hearing of how it is impossible to avoid the use of force for persons with psychosocial disabilities, but this is a failure of imagination. We have alternatives in our own country. We have one example of community-based care center in our country, which is run by a non-governmental organization. There are examples of peer support, open dialogue, family support, which have shown that involving a person in their own treatment is the only way forward. The current system operates in fear and creates uncertainty, strips us of our dignity and takes away our rights and does not do anything but harm. We all want the same thing, a safe, healthy, and secure environment where all of us can reach our potential and where we can be seen as contributors and not just consumers of services. We support this bill because it respects our voice and choice.
Order.
I take it we'll be hearing more from them. Thank you very much. Are the people in support of the bill, have they concluded their... If there is time, so if you want to make further points.
Well, on the yes side, we still are continuing.
Yes.
Yes, thank you very much. It's an honor to speak before this distinguished committee in the name of the National Institute for Human Rights. Hello, yes? We're speaking on behalf of the National Institute for Human Rights. We've reviewed the proposed bill and carried out a consultation with national partners, particularly with persons with disabilities. And we welcome the fact that users and survivors have had an opportunity to directly voice their opinions here, as nothing about us without us is truly what should be lived. We welcome this draft bill. We see it as a continuation of the human rights obligations of our country, and particularly that it embodies, as the Honorable Speaker said, the spirit of the UN CRPD. In my very brief presentation, I'll signal a few of the sections that the Honorable Speaker had mentioned and note the convergence between the draft bill and the convention. Before doing so, however, I would like to speak to the underlying values of this project and to the supportive policy environment. Deprivation of liberty and forced treatment on the basis of disability are unacceptable. No other person or group of persons having a medical, or we prefer saying medicalized condition, would be subject to deprivation of liberty and forced treatment. We could think of any other such condition, but we could use the example of cancer. No one is forcing people to have treatment or medication or to be confined because of cancer. And we've seen the idea of deprivation of liberty held up by two rapporteurs on health and also on disability. Under the current legislation, the only reason to deprive the liberty of a person with psychosocial disability is on the basis of their disability, and therefore it is on the face of it discriminatory. This bill, in essence, is addressing equality before the law. That is the main issue, and it embodies the spirit of the disability-neutral approach, which is much needed. The phantom of dangerousness, which is hovering about this room, has been used for far too long to deprive persons with disabilities of their liberty, and it is no way supported by scientific literature on harm or safety for the general population. We assume that our justice system can already and promptly respond to crime or to threats of crime from any person, and there is no reason to signal out disability as an element to take liberty away. In addition to our values, we think it's important to couch this discussion within the recent public policy advancements our country has carried out. Most notably, care services in the community are already taking place, based upon the piloting of the Eindhoven model for family group conferencing, and the government has ensured funding for them. Therefore, we need no longer to speak of alternatives to institutionalization, that is, alternatives to a formalized deprivation of liberty. Up to now, our legislation has been framed in a way of asking how and when should people be deprived of their liberty. With this bill, we're really flipping around the question and asking how can we ensure that all people can fully exercise their rights on an equal basis with others. So this is a sea change worthy of our country and its values. Now, as the honourable gentleman had mentioned about Bill Section 2, full and equal equality, legal capacity in mental health care, we see that is certainly mirrored with the spirit of Article 12 of the UN CRPD. I just want to draw attention to the fact that the general comment of the Committee on the Rights of Persons with Disabilities stated, particularly in Article 12, in order to fully recognize universal legal capacity, whereby all persons, regardless of disability or decision-making skills, inherently possess legal capacity. States must abolish denials of legal capacity that are discriminatory on the basis of disability in purpose or effect. We want to underline here that the only legitimate purpose for evaluations of decision-making abilities would be for assessing support needs, not legal capacity. As for deprivation of liberty, again, aligned with Bill Section 3 is aligned with Article 14. The committee has repeatedly stated, and the committee guidelines on Article 14 rather, states that states parties should repeal provisions which allow for involuntary commitment of persons with disabilities in mental health institutions based on actual or perceived impairment. And we see that the principle of free informed consent appears throughout the convention. We are taking an extended view of Article 15 on freedom from torture or cruel, inhuman, and degrading treatment and punishment, because we want to bring out that notion of free consent. No one shall be subjected without his or her free consent to medical or scientific experimentation. On a positive point, we believe this legislation could be in line with international obligation of not subjecting people to forced treatment, which has been through several rapporteurs and rapporteur on torture, certain forms of, quote, treatment or, quote, care, which we do not believe these forms of treatment or care, as they do turn out to be a deprivation of rights, that they really are caring. But it could be interpreted as cruel treatment or torture. In the end, we'd like to say the point on Section 5 is really where we see the added value. This is not just about a project that reflects the UNCRPD, but adds something else to the equation, which would be what you do when people violate these new standards. We assume that a regulatory framework will accompany this for retraining and education of the medical profession during a transition period, and then we would be in agreement, and we would love to work in cooperation with DPOs, with civil society, to provide support that these implementing policies and training of the medical profession really make this a true implementation of what should be a groundbreaking bill. Thank you very much.
Thank you very much for that. Can we have our next speaker, please? And I think we're well within our time limits.
Thank you, Madam Chair. Madam Chair, ladies and gentlemen, thank you for inviting us to speak before you in support of the Mental Health Service Users' Rights Bill. I represent a group of psychiatrists who have allied ourselves with the movement of users and survivors of psychiatry, and we support the inclusion of the UN Convention on the Rights of Persons with Disability and its principles in our country legislation. We welcome the new Mental Health Service Users' Rights Bill and hope it will bring the changes that we all so desperately need in our country. As psychiatrists, we operate on the basis of providing help to people who need it, and especially of doing no harm with our work. Our ethical commitment compels us to fully respect the dignity of mental health service users and their human rights. We are concerned with the psychiatry being seen as an oppressive system by many mental health service users, and thank you very much to our allies for presenting their stories. In many countries, psychiatry has been used as a punitive mechanism for political and other activists, which we fully opposed. We are here to help people, not to double their pain. That is why we welcome the United Nations Convention.
Can I interrupt just to ask you a question on the basis that I know that the people opposing are going to be asked several questions, and we're going to look biased if we don't ask you one or two? Could I ask you that in terms of psychiatry? Surely our mental health is what we are, how we are, and what we are every day of the week. It's sometimes good, it's sometimes bad, you know, and some of it can be enduring. In terms of psychiatry, do you think it's possible that everyone that interacts in terms of the medical profession I'm talking about now, in terms of aides that work in hospitals, psychologists, nurses, doctors, do you think it's hugely important that they would have more extensive training in that type of support, in that type of ability to recognise that someone is having a difficult day in terms of their mental health and how they would interact with them? And how do you think your profession would react to that? It's, you know, we're very conscious in Ireland of the sort of the closed shop situation in terms of unionisation and all the rest of it. How do you think your profession would react to that? That you would, in fact, I suppose, relinquish a lot of control, but only to allow others to become involved as well?
Thank you very much for this question. We see our colleagues opposing the bill today, which we regret very much. But we welcome this opportunity to have this dialogue because it's really important. We think that our colleagues see the importance of this bill today and the importance to work with the civil society and with organizations of people with disabilities and service users. This is essential. Thank you very much for bringing up the issue of the need for training and awareness raising and capacity building within the profession. And we are fully committed, if this bill is passed, to work with the government and with our partners from civil society on developing a framework that will allow us to have all the necessary resources to provide support for the decision making and for provide support for the decision making in the context of mental health. My colleague has mentioned already some models that have been developed in the community, and I would like to mention that as psychiatrists, we also have a duty to continue to study and advance scientific knowledge, but scientific knowledge comes from the experience, and we have to take into account the lived experience of people who are here with us today. Thank you.
Can I ask one further question? I think in the physical world, we have accepted that not everyone can be saved. We've accepted that. You know, not everyone can be saved from whatever disease afflicts us. I think we haven't quite come to that yet in terms of our mental health. I'm not saying in terms of psychiatry now, because I think it's wider than that. But in terms of accepting, you know, that some people's condition will be enduring and lifelong and will simply have to live, and we, you know, those of us that consider ourselves, you know, normal or whatever that means, that we will have to accept that people are different and that people have different ways of expressing themselves. I don't think that, I think that the whole area of psychiatry, counselling, all of that sort of vast area, I don't think they've quite come to that realisation yet. I think they are convinced that somehow or other their input will be of benefit to people, and sometimes it isn't.
Thank you. I can't speak for all the psychiatrists. I can only speak for those of us who are here today. and who I represent. And we have accepted this belief. We believe that the person should be in the center, at the center of all the decisions in relation to the treatment or refusal of the treatment. And we see in our experience that only the users who adhere completely to the decisions made in relation to their treatment are able to regain the full autonomy and reintegrate the community. And this is our ultimate goal as psychiatrists. And we just can't ignore the will of the person and treat them against their will. That will never work.
Okay, hopefully we won't have to call the bailiff. Could I ask this side one or two quick questions? One is legal. By the way, I'm not from the Minister's party. I'm from the FDP party, which is the fuddy-duddy guys party, okay? And my question is this. The Minister says the CRPD requires, but it's really the UN CRPD committee that's interpreting the CRPD to require a transformation of mental health law. And the views of the CRPD committee are not, strictly speaking, legally binding. So why should we go for one interpretation of the CRPD and not another? That's the first question. And the second question is, at least two of you said, we went through this and we weren't informed of our rights and they weren't explained to us. Well, shouldn't we just have a bill that says you have no rights and explain it clearly to you? Is that enough? I told you I'm from the FDP.
Can we take one or two? We'll just take another committee member, John.
Okay, thank you to each of the four speakers. I've two questions. The easiest one to put is the representative from the National Institute of Human Rights mentioned the importance of a transition period, and if I picked it up correctly, education or briefing or support to people involved in services and whatever during that period. Why would you not call for an amendment to the bill to make sure that that is solidly put into it? That's my first question. The other one, the second speaker, and again, the representative of the National Institute of Human Rights, second speaker towards the end said, a safe, healthy environment for all. Okay. So, and then the representative from the Human Rights Organization said, the phantom of dangerously, I've quoted that wrong. The risk. There's the phantom of this risk dangerously hovering around this room. Okay, that's very strong and also clear language. Yet the bill talks about in section 3.2 it's unlawful to involuntarily detain a relevant person on the basis of psychosocial disability and perceived risk of harm to themselves and others. It doesn't say the risk of harm, it talks about the perceived risk of harm. It is a matter of fact that some people can, or we have to allow for the fact that some people can behave in a way that's harmful to others. I'd like to hear that thought out a bit more, because if you can't protect one person's rights at the expense of somebody else's rights, and you have acknowledged that already. Thank you very much.
Thank you so. Hello. Thank you so much for those questions. Let's get to the sense of perception of harm. Again, no other person with, and I use the term again, medicalized condition, would we assume that that person, we all are inherently harmful or helpful to anyone in society. So to say that because a person has a defined medicalized condition would then be automatically harmful, or the potential to be. We think we can go all the way back to Plato's Republic, where he asks the question about, should you give a sword into the hand of a madman? And there must be some sort of limit on liberty. But that sort of discussion was taking place within a society where slavery was acceptable, where inequality between genders was acceptable, and we have moved on from there. The idea, this automatic millennial assumption that there is some sort of risk inherent in having a psychosocial disability. I think I'll take that next after answering your other questions. In terms of, so in no other condition would someone be assumed to have a medical, a clear and defined risk to society. We have used this example previously about, if you look at statistics, young men, drunk men on the street on a Friday night may pose more of a harm, hold more of an immediate threat to all of us, and yet we do not go with the wagon and round them up before Friday night. In terms of a transition period, in terms of transition period, we in the National Human Rights Institute discussed this because one could either take the notion that we must have all national legislation in place and then we're ready to ratify and implement the UN CRPD. Or you could take the idea that this is a progressive instrument that's taken far too long to be accepted. Most of the world has accepted it already. The country has signed it. So we assume that a transition period needs to be put in place, such as community care, training, etc. If we were to take the time to amend and to change that ahead of time, we may just lose this train, this historical train. And we're all moving towards this direction, so it would be better to move ahead quickly. From the first, the gentleman who posed the first very easy question to answer, you mentioned about the committee, and just generally in human rights, and you already know this, but when states take on these when these states take on obligations, they take them on. We would say with free and informed consent. They bind themselves. The country has already signed onto the UN CRPD, and it comes. We have learned that the rapporteur is not an antagonistic relationship because the position came from social development, then moved into disability. It seems to be tied with the core needs of the country. So I would offer an interpretation that we don't need to see as an imposition from the committee. Rather, that person, that office is helpful to us in implementing our national dreams, which in this case is to get equality for all. Thank you.
Okay, quick supplemental. You actually haven't answered the question, which is the UN CRPD committee takes one particular view. The minister happens to agree with it. Many of the states parties don't take that view. The treaty is of course legally binding, but the edicts from the committee, at least there's a question mark over their legal status vis-a-vis countries. I'd add to that, this legislation will be on the books for 20 years, right? And we don't yet have really in place the building blocks for the alternative to civil commitment and forced treatment. Shouldn't we wait until we have that in place before we legislate the abolition?
Thank you so much. My colleague here, I think I would like to have her answer.
respectfully, I would have to disagree that we don't have.
Every time someone says respectfully, they're about to insult you.
I'd have to disagree that we don't have the building blocks in place for these other methods of treatment. There have been numerous pilot studies of different programs that do show results, and we think with government support, these programs could be launched on a much larger scale, and that the models are there. Now we just need the resources. As far as the different interpretations, while the committee and any country is free to take to interpret the language in any way that they choose, it would be best for our country to be forward-thinking and to not be left behind. And so by taking this interpretation and being one of the first to formally abolish forced treatment, we would be setting an example for the world, and we would be really putting pressure on the rest of the world to come and join us.
Yeah. On the possibility of on the possibility of amending, we had thought that it was important to move forward on this topic right away since it's taken so long, and that we could deal with this in terms of implementing legislation and policies around the environment. Yes, that was our approach.
So you wouldn't consider putting it in, having it as an amendment to the bill?
Again, for the urgent and political the needs of the people at this point, it would be better to advance on the as it stood, because it does reflect the spirit of the UNCRPD.
We represent the taxpayers and the people at large.
We are taxpayers.
Thank you for your money. Why not an amendment to the effect that we're going to implement all of these support programs, we'll review them, and at a period in the future, let's say 3 years, then we'll take a principled decision whether to abolish forced treatment and civil commitment. Would that not be a more prudent approach from the taxpayer's point of view?
We can't have any kind of programs if we still have any kind of forced treatment or coercion. All these support programs and models that are existing in the world, they can also be used to do coercive treatment. So we have to, in principle, abolish all kinds of forced treatment, all kinds of coercion, no treatment without informed consent, because otherwise we'll just be going around in loops and the taxpayers' money will ultimately dry out. Also, research has shown that by all these support, different kind of services that we spoke about in our presentation, open dialogue, family support, peer support, in terms of resource, they actually cost much lesser in terms of having large institutions and forced treatments and electric shock treatments. So in terms of that, the taxpayers, I think, would be really happy to have a lot of money freed up, and then we could use it for some other sustainable development goals. Thank you.
Thank you very much. That was very interesting, and I'm glad of the questioning and the interjections as well. I think it made it more real, and I think did bring out the type of passion that I feel sometimes is lacking in terms of, the standard presentation. I think that passion comes out much better when people are under pressure and are being questioned. Now we have the people for the how will I say this? The people with the uphill struggle, even though it should be the other way around. And we have the team again. So would you please, before you speak, would you introduce yourself and the organisation you represent?
Mr. Speaker, my name is Jón Þorsteinn Sigurðsson, and I'm speaking for Cross-Sector Disability Group. He didn't write my name right.
Are you ready?
First is to say that this bill is an idea on good faith. It's a right step forward, and I agree to my opponents that it's somehow a micro steps towards rights. But the question is, are we here to take micro steps towards rights for a person with any kind of disability, or are we here to take big steps? That's the reason we oppose this bill. And we doubt some things in the bill are not there to stand for its rights. So first of all, the bill doesn't include all persons of society. In the bill, it mentions in this act, save where the content otherwise required applies to adult mental health service user, adult persons. According to the CRC, it states that children has also a legal status in society. And we sort of want to include every person in a bill like this if it should pass. We also look to intersectionality, women and other minority groups that often are not mentioned in the in the bill. And it also required that the 12th article of the CRPD should be looked at better in that sense. We should include all persons with disability, not only a chest heart of a person. Then the second thing we want to point out to the committee is that the bill should take notice of the social model much better than it does in these papers. Meaning that we should look to legal capacity. And maybe I state what I'm meaning. Definition of legal capacity. The recognition of the right of legal capacity in the CRPD signifies that all people have an equal right to make decisions on their own behalf, without the right to make fundamental decisions such as where to reside, any kind of medical care to reserve. A person is regulated to the status of an object rather than independent human being with thoughts, emotions, and opinions. So, in this bill, we don't think that the legal capacity is highly reckoned. It doesn't clearly say that a person have a support in decision making. It doesn't clearly say that the supporter or any kind can step in if the person doesn't understand what he is clearly told by, for example, my medical doctor. That means that a person can undertake a medical treatment that is, according to the 15th Amendment of the CRPD, is a torture or forced treatment or any kind of that. It states in Article 12 that states parties shall take appropriate measure to provide access by person with disability to the support they may require in exercising their legal capacity. We think, in our DPO that this doesn't say in the bill. Doesn't, for example, mention any kind of peer-to-peer support or any kind of support. So we need to clear that in the bill, of course. So
Sorry to interrupt you, but are you against this
against,
bill?
yes.
Are you against the bill, or are you just for certain improvements in the bill?
I'm against it because it doesn't have the improvement it needs.
But if you amended the bill, would you accept the core of the bill?
We have to take a look at the bill and before it is taken to that kind of So the fourth part that we like to point out, we think that the fifth article of the bill is a kind of a danger to people with mental illness and all disabled people. We take out one party of the people, and then, of course, we find the other that is making the treatment. Shouldn't do that, because that can lead to similar discussion Ireland has about abortion, where the doctors are afraid to take a necessary life and death decision to save a life. If you take one party out of the group, for example, we take here in the bill medical doctors that are making service to disabled people, then of course they might stop the treatment. They might just get another job, go serving gas or something in a gas station, or so they won't be fined 50,000 euros. So this bill has to, if it is to be, something that states all parties. And it has to be a committee that concludes and are neutral in taking decision and taking argument from all parties. So this is sort of a few points that we have, but I want to end by saying we would, of course, the committee should, and the parliament and the minister should, of course, have us on board on these making of the bill. It's quite appalling that you didn't have us present when writing the bill. And I want to... And it is, of course, my counsel say that it's against the CRPD. And I think that Mr. Quinn told earlier this week that a bill like this should not exist in close future. So the question is, why in the hell are we talking about it?
But just to be 100% clear, are you in favor of abolishing civil commitment and forced treatment?
Can you ask that question again?
The bill purports to abolish civil commitment and forced treatment. Are you in favor of those objectives or not?
It's a really good question you put to me, and definitely it deserves a great answer. Of course, I want to abolish that kind of a treatment you mentioned, but of course it should just be a human right included in all other laws. So we don't need to make a special bill that maybe close a special group into a special legislation that can affect others. So this bill doesn't include all others, like I mentioned in the beginning.
Are you suggesting that there should be no form of incarceration across society?
You have to declare the question a little bit better for me.
Are you a politician?
No, I don't work for the government, but... Can you refer to the question again a little bit?
If you want the bill to include everyone in society, and are you suggesting that there would be no incarceration across the entire society, illness or not, or whatever the circumstances? Are you suggesting that there be no incarceration?
Again, I'm going to refer to, it's a really good question, and I'm going to refer the question to my counsel behind me that has a better view on those matters.
Very good afternoon. I represent the team of psychiatrists who are opposing the bill. And so it seemed to us that the bill was drafted with all good intentions, and it seems to be compliant with the human rights standards and the CRPD standards to support people with psychosocial disabilities. But in fact, it seems that it might actually be doing the opposite and erecting a number of barriers in things which are already supporting people. And this could, in fact, have a further detrimental impact on persons with psychosocial disabilities and on their families. Because, one, regarding the right to life and health, Article 10 of the UNCRPD says that every human being has the inherent right to life and shall take all necessary measures to ensure its effective enjoyment by persons with disabilities on equal basis with others. Now, the other reference that I want to quote over here is, as a psychiatrist, the Hippocratic oath that we take before we join service is that I will apply for the benefit of the sick all measures that are required. Secondly, I will remember that it is but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I am to care adequately for the sick. So we are talking about not just the right of the individual, but also right of others. And in that, just to quote an example, this is discriminatory because if someone was to come to the emergency room with a heart attack or a stroke, and that person is not able to give consent, that would not stop me from treating the person in the way I think is the best way to help the person at that point of time. So if somebody is coming to me who's attempted suicide or who is wanting to end their life, why should it stop me to treat the person at that point of time? Secondly, more so if they are not...
Keep going, we will protect you.
Thank you. I know I'm safe. Yeah, okay. The second argument is that, the right to liberty. Again, it is about individual rights versus rights of others. I think the right to liberty can be enjoyed as long as they do not infringe on the right of others. Now, when there are people who are, who come from intimate situations of violence in families, where children are affected, spouses are affected, where there are other persons with psychosocial disabilities who are affected, where there are other people with disabilities who are affected, then there is a choice that we have to make in those circumstances. With respect to crisis situations, for example, if this bill goes ahead and it becomes an act, then you take away the necessary tools for supporting the person at the time of crisis and for also considering the situation of the others who are being impacted, in fact, by the person. The third argument is the right to self-determination. I do think that as psychiatrists, we are in fact supporting them. We do give them information, we talk to them, we give them time, and we do take decisions when they are not able to do so. And there are very real practical difficulties on field. When somebody is coming to the emergency room, we are at the front line and we have to decide right there. And it really leaves you very little time to go through many of the other protocols, including informed consent. At times, the person may not be able to give informed consent. So in that case, I think it's better to resort to paths that are known, that we have been doing so far, instead of talking of a wishful dreams, which, nowhere in the bill it says what should be done. It is a visionary statement. It is not giving any practical guidelines on what really needs to be done. So it's safer to do the things which we already think are, they go a long way in saving a number of lives, not just of the individual, but also of families. Secondly, there was a mention about life expectancy in terms of using psychiatric medications. Let us consider this case that, say, somebody has a life expectancy of 100 years, and it gets reduced to, say, 75 years because the person is being administered psychotropic medications. But if the person decides to kill themselves right now, they won't even have those 75 years to live. And then it mandates me to do my duty at that point of time. And the other argument is that I think the criminalization of psychiatrists is what is happening over here. And we are being targeted, we are being victimized. And in fact, we are the ones who are the saviors, and we are in the front line. I mean, nobody can deny that. And it's very unfortunate because, we think we are important stakeholders, but never given the role of collaborators or partners. And whoever has drafted this bill, I am not too sure if, they have had people who have had difficult family members to take care of. Whoever has drafted this bill, are they thinking about the others? So with all due respect, I think the bill compromises our position for necessary and appropriate responses without really telling us what to do. Thank you.
So can I ask you? Can I ask you, and I'm sure the other side will have a problem with this, but would you be willing to accept a simple amendment that states that this bill is otherwise valid, but normal practice in existing emergency situations is accepted? In other words, it can go forward alongside the bill. Simple amendment that says anything in this bill does not affect emergency situations where normal practice will continue. Would you be prepared? Crisis, yeah.
I think this bill is actually in contradiction of a number of other treaties. I would like to quote the Oviedo Bioethical Convention over here, which the Article 3 on legality, which says that measures for involuntary placement and involuntary treatment shall only be applied in conformity with the provisions set out in domestic law. Secondly, the Article 4 on necessity and proportionality, which says that it shall be only used in accordance with the principles of necessity and proportionality. And which is actually happening right now. Nobody is denying that. And also the European Convention on Human Rights, the Article 5, which mentions about persons of unsound mind, alcoholics or drug addicts or vagrants. It seems that there are a lot of disagreements between the different treatises, and while the disagreements are going on, there is no agreement, and there is no agreement. And in fact, if there is no uniformity, or if there is no standard things that are holding the different treatises together, it really makes no sense to just push it across. I would say that you sort this out first at that level before actually getting it down to, coming down to the domestic laws then, and then to the field.
So, very quick supplementary. We are mere backbenchers, but Yoshi is the man who makes all the decisions. And when Yoshi talks to his Attorney General, the Attorney General says, well, we've one treaty that says one thing, another treaty that says another, and yet another treaty. How's he going to choose which one to prioritize? I'm sure the other side have a view on this.
That's why we've all got caught in this. And and that's precisely the point of, if you want something to work out, it has to be in collaboration. You cannot leave the psychiatrists out and criminalize them with a bill like this and then expect that all disagreements will be resolved.
In that sense, of course, we're going to emphasize. It's appalling that you didn't have us aboard.
Can I, on the basis that psychiatrists are such an endangered species, can I'm much set upon, you're right. Could I just, I think that if you were to adopt this bill, I'm not saying what side I'm on, good, bad or indifferent, but if this bill were to be adopted, surely it would take the significant pressure that psychiatrists are under off them, because you are talking about, I suppose, a clearer framework about what you do, a team of people that would decide on the care plan, with the person themselves in the room, or sometimes maybe with an advocate or someone that can interpret their will and preference, and that would, I suppose, take the significant pressure off the one single person. Who always seems to be the person that has to lead the team, that has to make that decision on their own. And surely a bill like this, with, I'm sure, as the Minister will provide, the type of all-encompassing regulation in terms of teams and how decisions are made, surely that would make a significant difference to your mental health.
I am not too sure because, at least now psychiatrists are responsible. You have somebody you can talk to, somebody who's owning up the decision that they have made. But when it is about a team, and then and then something happens where, people will just push responsibility on each other, and then I am not too sure how it will fold out because it has not been tried so far. And so I am assuming that if there is a team, yes, there will be a sharing in terms of caregiving responsibilities. But again, it zeroes down to that moment where you have to make certain hard decisions, and that decision the psychiatrist has to take. If I have to administer ECT to somebody because they are very, very suicidal, I don't know how a psychologist would help me make that decision.
I ask a few questions to the psychiatrist who's well read in a range of international treaties. You put a lot of stock or a lot of emphasis on the emergency department, for instance, the human rights of everybody, and respecting those having to make a decision at a particular point. So how do you see how would you exercise choice in a way that upholds the human rights of everybody in a context where we have one group of people, an individual, let's say, who is there with an already existent or query around a psychosocial issue? And is it right to actually allow for other people's rights to be slightly diluted in a situation like that. It's what I mean, that seems too raw now. What I mean by that is that we expect that those, we talk about income tax, those who can pay more, who earn the most, pay the most, to support those who are not in that situation. That's a particular way of trying to do the right thing by everybody, realizing that some people are not in such a good situation.
I think the scope for dialoguing, time has to be given to that, and time is an important factor over here. Certain spaces, yes, you can have those kinds of exchanges where people can have those kinds of dialogues, and we come to some kind of an agreement on what is the best way to go forward. But again, it has to be seen in context. One, there are people with psychosocial difficulties. Two, there are people with psychosocial disabilities. And the context for both of them are going to be very, very different. When we are talking about the right of, say, an individual, we have to consider if there is another individual with a psychosocial disability who's being impacted by this individual as well. So, it really depends upon context, and I think these will only come from live examples and experimentations, and it's not something that we can talk right here, right now. It has to be very much in context.
Is there something, this is our stock question now, is there something that could be as an amendment in the bill that could provide for that?
More than the amendment of the bill, I would say if you are drafting a bill, it would be great to have a team of people who are representing different stakeholder groups to sit on the table, talk about the barriers that they are facing, and then draft a bill which kind of includes all perspectives in a practical way. So, the amendment would come to, the amendment is something which will be done in the existing bill, right? But I am saying that before even you devise a bill like this, it might be good to have some kind of a collaborative dialogue on
is it too late now?
Sorry?
Is it too late now if the minister decides to actually press the hold button and say, okay, I've listened to you, you've made some very interesting points, I'd like to sit down with you and others and see, could we fashion an amendment? Would you be saying no to that?
No rights on hold! No rights on hold! No rights on hold!
I think if that kind of an arrangement can be done, that would be perfect.
Okay. I have one other very short question, short question, and maybe you can deal with it quickly enough. You made a statement that psychiatrists are responsible. How do you make a statement that a whole class of people are responsible? And to whom are you suggesting they're responsible?
Because it seems like the whole debate on medicalization and coercion and institutionalization on force is targeted against psychiatrists, because that's the way the discourse sounds. When people are making arguments, it is always about my psychiatrist did this to me, and this is the way I was treated. Of course, and the only person who's treating somebody biomedically, somebody with a psychosocial disability, is a psychiatrist. It's not a general doctor or a general physician. And
but isn't that because the psychiatrist insists on being the person in charge? Isn't that the case? I mean, if for instance you I have a supporter. I don't mean that's not no. No. But the question I was asking a while ago leads into what John is asking. Surely, if you have a team of people and there is no hierarchy, and the psychiatrist just happens to be one member of that team, and the team being the community nurse, and the team being the person themselves, and the team being an advocate, and the team being your GP or the tribunal that normally sits, and someone that has, I suppose, civil society's view of the world. Surely it takes the pressure off a psychiatrist. I'm saying this from the point of view of easing the pressure. Surely it must be that way. But the only people, in my experience, that have insisted on being the head of the team and the person in charge is the psychiatrist.
Yeah, and I guess that's because psychiatrists have been excluded from things like this, you know, and I mean,
Order.
Yeah.
Order.
You give us a bill and you ask us to comment on it without actually involving us in drafting of the bill. That would see that you are already excluding us from the process. And then you are talking about getting a team together. I mean, I don't think that's fair at all. Partnership has to be done at all levels.
But we've opened up the parliamentary process to take evidence precisely from people like you. The difference being that it's open-ended and everybody has a voice in the process, and we're not privileging any one group like psychiatrists.
All right.
Thank you.
Yes.
What does the last speaker mean by people like you?
I'm glad you asked that. I'll pass it along now.
All right, it's me now. Okay, so good afternoon. My name is Eva, and I represent emergency mental health care workers. So we have reviewed the bill, and we have some comments on the bill. So we as emergency mental health care workers, we are the first people on the scene when things happen, when crisis happened, and assist the psychiatrist. So what we found when we reviewed the bill is that it doesn't cover emergency situations. We also have a couple of comments of who is the patient. Is it an adult, or does it cover persons under legal age as well? Further, we had a couple of comments on the issue of consent. What is consent? We believe it needs definition. When is it valid? Also, what usually happens in a situation, we are called in and we make a verbal contract with the person about usually taking them maybe into a hospital. Then they change their mind, they go into a state, they change their mind. Which consent do we take? Do we take the denial? Do we take the consent we had been previously given? Usually in our jobs, we don't use coercive methods unless it's a last resort. So we use negotiations, incentives. But under this bill, would that count as coercion? So we wish for things to be more clarified in that matter, and maybe implementing about emergency advance directives for us to fall back on. We also raised the question of responsibility. We do have a duty of care. And the definition in Article 2 of full and equal legal capacity, where does the responsibility lie? Does it with me as the emergency healthcare worker, or with the person with who is in the situation? And if they refuse treatment, if they send us away, under legislation now, it is neglect and abandonment, and we are criminally liable. So how do we approve the refusal? How do we take that as a consent for us to leave? Because if they would harm themselves afterwards, we are criminally liable. Also, we, of course, have an issue with Article 5, as what is my right to protect myself, as we do take courses and we are quite educated in physical interventions. which aim to not to intervene without harming the individual. And we are in a situation where harm is real. So what is my right to defend myself if I should face either the criminal penalty or fine? And also, if with Article 2, would the person with full capacity be liable for their action if they were to attack me in the situation? So also, in our job, we make a judgment call, which is an emergency situation, and we have a split second, just as was previously described, to make a decision. And if we make the wrong decision, are we then also criminally reliable? Also with Article 2, who does the evaluation and what is meant by specific tasks? We believe this needs to be clarified. So we would propose a clear protocol for emergency situation and put somewhat of advanced directives in place. We wish for mental health services to be further defined in the protocol, no, in the bill, sorry. And let me just refer to my notes. Because we do work in quite ambiguous situations. So we wish for this to be clarified. Also, would this bill make me a better healthcare worker? That's what we actually find quite problematic. And would this bill ensure the person's right to health? So, to conclude, of course, we support increased rights for persons with psychosocial disability, but on these grounds that the problems raised, we unfortunately cannot approve of the bill. Thank you.
So if the bill adequately catered for emergency situations, and if we exempted you from liability for civil suit, would that be the sweetener that would get you over the line to support the bill?
Can I just add to that? Is it possible to sue your psychiatrist? Or would you be considered not a reliable witness on the basis that they didn't do their job?
I just drew the last straw, that's why I'm here. It's peer pressure, so I'm just gonna say it's appalling you didn't include them in drafting the bill. But your question was, sorry?
It looks like you're willing to move toward maybe an amendment to the bill whereby emergency situations are not to be affected by the content of the bill, but also you're worried because of your duty of care that you're going to be civilly sued or maybe even criminally prosecuted if you even unintentionally cross the line. So what I'm saying is that if there were another provision in the bill, an amendment to the bill, that exempted you from liability in bona fide situations, would that make you more amenable to the provisions?
Not necessarily exempt. Of course, we were emergency mental health care workers are working with vulnerable groups. So if they overstep the line, of course, they're liable. But with the ambiguity of the situation, we believe that the bill needs to be clarified because of course, if you intentionally oversteps, which unfortunately happens, of course, you're liable. But with a situation like that, things run fast, split decisions are made. And we necessarily don't believe that it's either beneficial for either the person in question or the healthcare worker.
Just to refer to your question, well, what kind of a bill are you putting forward, or the minister is putting forward, which will, as you told before, last for the next 70 years, if you are always going to do experiment on the people that the bill is talking to or are for? So if we always are getting into legal boundaries of the bill, which includes all parties in the bill, meaning that all parties should have been part of the draft of the bill, and then of course the respect for the people the bill is about is also throughout the people that serve that people. So my DBO are concerned that the bill isn't ready to be put forth and to put in because it hasn't been discussed quite enough. It was a DPO.
Can I add? I just want to say that I am in agreement with my colleague here because it seems to be premature because you're talking about something for which there are no supportive structures, there's nothing on field, there's nothing at all, and you want to pass the bill and make it into an act, which is very scary, then so you have to consider these things, and it does mandate representation of different kinds of, again, coming back to the same point of, if you're drafting something like that, then there has to be a representation of many kinds of stakeholder groups, including families and carers, including welfare staff, including people from the social developmental sector. So it seems to be quite premature at this point of time, which is why also we are opposing the bill.
More action, less talk. 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 More action, less talk.
So the process is problematic. By the way, we're just backbenchers. The minister is in charge of the process.
We know.
But then in terms of substance, there's really three net points. There's the case of exceptions and emergency situations. There's the case of liability and perhaps some relief from liability, not complete relief, but some relief. And then there's the question of, should we take it more progressively and implement the bill once the supports are in place and have maybe a transitioning period? So would it be a question of drafting amendments along those lines to make the bill acceptable to you? Presuming the minister can fix the process as well.
Probably, yeah. But also, what seems to be the problem in most cultures, my country as well, is that, I mean, of course, we welcome bills of equal rights, and but as the bill, how it is at the moment, it's not inclusive as it would have to be, and unfortunately, if I just look to my own country, even though we're supposed to be, we're a Western country, and what you would call a developed country, but we are severely deprived of funds, and we would have to look into further change of infrastructure before actually implementing the bill.
Would you agree that the bill is a good beginning in terms of talking about the situation and how in fact we actually resolve it, and how in fact we come to the point where we can in fact have the type of society that we all want, and I'm sure that you want it as much as we do, but would you agree that the bill is a very good starting point and that the other processes can be put in place?
Definitely. Even though it just starts the conversation, it's still a step in the right direction. And all conversation, even though we want more action, all conversation is good. And it starts with a conversation.
I'm confused now, because a bill isn't about a conversation. It's about making a decision that's binding on everybody.
And in this form, we can't accept that, unfortunately.
Could I ask both sides to maybe give us their final thoughts? 1 minute, I'm hoping the timekeeper is still available to us. 1 minute each side, and I would appreciate it. And we will start with the people for the proposition. Take your time.
Mr. Speaker, is it a minute by each person?
I'm going to start it because I'm just giving you a minute to, it doesn't matter which one, a minute to sum up. We're going to start with the people in support of the bill, just to give you a little bit of time to gather your thoughts because oh no, one person.
Thank you very much. In summation, I think it's really very simple. This bill provides a great step for persons with disabilities to make choices and have their voices heard, and that's really all we want. And so, therefore, we support this bill because it gives us informed consent and stops us having to be forced to be treated when you wouldn't do that to any other group. So.
Thank you.
Mr. Speaker and Minister, I always lose in straw competition, so I was the one who have the minute. We oppose this bill because in the current form, it isn't ready to be implemented into the country's law. We have to include more talks, we have to include more discussion between stakeholders, and also we have to include the real conventions that are in session around the world, the CRPD, the CRC, and European human rights law, and so on and so forth, because this current bill doesn't reflect the understanding we have on those factors. So again, we oppose this bill and would come with a suggestion that the Minister would have a meeting after 5 minutes to discuss a new bill that we, of course, would help him to write. Thank you. The draft.
So if you please stay in your seats, we'll just deliberate for a few minutes and we'll come back, and then you can go for coffee. But we want you to vote on whatever recommendations we're going to put forward, the whole House. You're all parliamentarians today. So just wait maybe 5 minutes and we'll come back to the room.
Yeah.